Thank you so much for having me, and it was really such a pleasure when Rena emailed me to come. And I'm really excited to talk today about some of the work my colleagues and I are doing down the street at NYU. Simulation for safety using unannounced standardized patients to integrate education, quality improvement, and research. So I have no disclosures. So what are unannounced standardized patients? They're highly trained actors who portray incognito and standardized clinical scenarios in actual practice, secret shoppers. They're used in business a lot, and we're taking that to the next level and thinking about it in medical education. They're standardized, they portray the same condition, the same patient characteristics, and they capture the providers hopefully free from bias, not knowing that it's happening. And they're highly trained and they become very, very experienced, and we'll talk a little bit more about that later. And it happens in the real world, in the real clinics where residents are seeing their patients. So this is not new, as I said before. Unannounced standardized patients have been in the literature for the last 20 years. They've been in over 9 countries, from India to Holland to England, and all sorts of providers, ophthalmologists, pediatrics, call centers, rheumatologists. Very few have been used with trainees. A majority of the work, so there was 92 publications from 1995 to 2015, and most really focused on assessing the clinical quality. So sending an unannounced standardized patient into the clinic, what happened, and reporting back on it. There's been some that's evaluated educational interventions. Here, let's send the standardized patient in, see what our learners are doing, let's give them a workshop, let's give them a web module, let's send the standardized patients afterwards and see if there's any change in behavior. And there's really about 4 distinct research groups who are writing about this. Saul Weiner in Chicago and Monica Lipson, University of Michigan, really are the other groups who are talking about this. So my background, how did I start to do this kind of crazy, kind of fun educational work? I'm a medical educator and an education researcher, and I, with my colleagues, really developed a comprehensive OSCE program using standardized patients to train doctors like many of you do here. And our goals were to educate and train the primary care residents to provide safe and effective care. And ultimately, the holy grail of medical education, to link education to outcomes. And we're thinking about identifying the educationally sensitive patient outcomes. How do we know our education is making a difference on the patient end? And so we're using USPs as a tool for overcoming those key methodological challenges in this difficult work, because this is hard. David Cook's wrote about it. It's really hard to make that link. So this is our attempt. So just like here, OSCEs, which are objective structured clinical exams, are totally embedded in our education at NYU. As many of you know, it's part of the licensing exam in order to, when you finish medical school, before you can go on to residency. So we start in the first week of medical school at NYU, sending our learners to OSCEs, and we go all the way through 12 different residency programs. We have over 40 standardized patient experiences that our medical students probably see over their time. So they get lots of performance-based assessment and lots of feedback. It really is true. The first patient our learners see in their second week of medical school is a standardized patient. And so, for example, they see Pedro. He's an 18-year-old diabetic who stopped wearing his insulin pump because he wanted to be on the basketball team. And these cases, they don't have the skills yet to do, really start to sensitize them and start their receptors of trying to figure out what do they need to learn over the next 4 years, communication skills, patient education, and also to start thinking about context matters as we take care of our patients. So we have more than 1,000 medical students, residents, and fellows annually who go through performance-based assessment up at NYU. We've developed a case bank of over 500 cases, and we have very specific checklists that we've developed, behavioral anchor assessment tools that have evidence of some reliability and validity. And we have close to 2,000 medical students and residents in our medical education research registry, which later on I can talk more about. But we created a registry in order to lower the bar for our faculty to do scholarship and really take this data unidentified and look at it and think about it. So this allows us to do this. If you look at communication skills, starting from medical school all the way through residency, it's a very busy slide, but if you look at the x-axis, you can see all the different activities that start with performance-based assessment, looking at communication skills. And if you look at the y-axis, we have the communication skills as rated by the standardized patient as percent well. And if you look at the blue line, that's a trainee who started the first day of medical school and gone all the way through a residency program and has actually seen some unannounced standardized patients. And if you look at the red line, that would be the average mean of the class. This just starts to give you an idea of how you can start to look at data and think about education and what we're doing. So we've been using OSCEs, a simulation, to measure competency. We do it in a really controlled environment that's really focused and really clear. But the real question we had was, what happens, how do those skills transfer into actual practice, into the real world, where it's not focused, it's very missing, and it's very chaotic. So, and our learners, and I have to assume your learners are similar to my learners, say, this is not how I really perform whenever you watch them in some performance-based as OSCE. And so my group and I, this is how it all started, we really wanted to answer that question. It was a good research question. What really happens behind closed doors, and what can we say about that, and how do these skills actually transfer? So I'm going to take a moment and sort of give you our framework of how we're thinking about this for linking our education to outcomes. So our goal, as I said before, is to educate residents. We're using the OSCEs to really focus on measuring their clinical competency, and we want to see how those transfer to the patients and their health outcomes. When we think about the outpatient setting, we think a lot about chronic disease, and what are the outcomes? We want to see behavior change, medicine adherence, follow-up, and management. In order to get there, we need activated patients, right, in order to change their behavior. And we as educators spend a fair amount of time teaching these competencies, communication, patient education, counseling skills, because we believe it's going to change patient activation. There's a lot of literature out there that patient activation leads to better health outcomes. More activated patients show up to their clinic visits, they take their medicine, they have better blood pressure. Lots of work has been done on that. So we are starting to look at patient activation as potentially an educationally sensitive patient outcome. If I, as a teacher, do a really great job at teaching and they have these great skills, we're going to move the needle on patient education, which is going to lead to behavior change, which will lead to improved outcomes, right? But what happens in actual practice? Competency versus their actual performance when it gets much more messy, which made us think about there's a whole lot of other skills that go into activating that patient besides the competencies that we're teaching in this nice, neat world. Charting, use of EHR, interpersonal collaboration, teamwork, navigating, that's all going to influence the competency that's going to be played out in the real world. So we're calling that the clinical microsystem, and that's the place that the care happens. So if you put that all together, we are pushing out simulation into that clinical microsystem and using unannounced standardized patients as a way to measure the competencies that are going on. So far? So what have we been able to find doing this? And we're very fortunate, as we started thinking about this, to apply for an AHRQ grant looking at outpatient safety and being able to have the resources to start thinking this through. So we're able to use unannounced standardized patients to give feedback to our learners, to provide actionable quality improvement data to our clinical systems. We have a partnership with our clinical system with this, and to answer some core research questions about the clinical competency, practice, and outcomes. Taking a moment to step back to think about outpatient safety, we believe literature supports that effective communication skills with patients is key to outpatient safety. More, it's inpatient, but outpatient, you don't see them for a while. If we don't have those communication skills with the whole team, that's where we're going to have some problems. So again, physician communication skills lead to patient activation, lead to patient collaboration and care, and positive outcomes. These are the core skills that have to happen, not just the physicians, I probably should say the team skills on this. And if these fail, then they lead to medical errors. Anyone who works in the outpatient setting knows that if you don't have a follow-up plan, or people get lost through the cracks, it's all based on communicating better to our patients. So we designed a set of 6 unannounced standardized patient cases: hepatitis B, asthma, knee pain, well visit, back pain, and fatigue, that all had embedded outpatient safety issues. What was common about them is that they all enabled the learner to have to gather data, patient education, patient activation, and again, address a patient safety issue. So for example, we have a 22-year-old young man who comes in complaining that he's tired all the time. The goal for the residents will identify the symptoms to make a due diagnosis. Again, he's a standardized patient. We can set what the diagnosis is. His PHQ-2 is positive. His PHQ-9 is always 14. We know what his symptoms are going to be. That's rare to be able to have that opportunity when you're looking at how all your learners perform. And the patient safety issue in that case is for our learners to be able to recognize and respond to depression, to make the appropriate follow-up, and also for us to see how well are we training our learners to take care of a really common and core diagnosis in the outpatient setting for primary care. So we've been doing unannounced standardized patients since 2009. We have sent over 561 visits to our clinical sites, and 208 residents have participated. And they range from anywhere from 2 to 5 visits per resident at 2 different sites. We send them to our 2 urban safety net outpatient settings, and they're all new patients who really represent the population in which our residents are caring for: Bellevue Hospital Ambulatory Care Clinic and the Gouverneur Healthcare Service. This is where our learners have their continuity clinic. And I'll speak briefly as we've also been piloting it with our medical students in Bellevue as part of their ambulatory care clerkship. So how did we do this? That's always a question before I get to what did we find. As you guys know, with standardized patients, there are a lot of actors in New York, so finding them aren't a problem. But finding people who have the right mindset for doing unannounced standardized patient work, it may be a little bit different than the OSCE work. They have to have a little tolerance of chaos and waiting. We have minimum of 4 actors per case. We train them similar to you would do for an OSCE, 4 hours or case portrayal, 3 in-house hours for case assessment. We do some video module online for training. We do some quality assurance. We review the audio tapes. They go in with an audio that it just goes on when they're in with the doctor, not when they're outside, not when they're with any of the ancillary staff. So we review that. We have more than 85% content accuracy, and we do some inter-rater reliability checks by listening and looking at the checklists. Everyone asks about detection. It's an issue. You have to address it. We minimize it as much as we can. They change what they're wearing. We make sure we have schedules to make sure they don't go to the same module on the same day for the same, different learner. We have less than a 20% detection rate. And interesting, most of the detection happens after the visit. It's because, they told me they couldn't get the labs. They didn't show up, that really depressed guy. A lot during the moment, they feel it's real. We looked at those who identified people who they thought were a USP versus not a USP. Did they perform differently? They didn't. And the other part, which is interesting to me as a preceptor, is there's a lot of false positive. I know this is a standardized patient. They come into the precepting room and I say, okay, so tell me why. And they start to tell me they have this big rash or this acute problem. And I'm thinking, that is just not happening. It would be nice if I could do that. So there's a lot, and so it's a teachable moment to say, standardized patient or not, treat everybody as if they are your patient. And we tell all our learners that over the time of your course here with us, there's going to be 3 to 5 standardized patients that you will see as part of our programmatic evaluation for our residency program. And then I'll tell you about how we give the data back to them. But this is part of what we do for everyone. And so it took about 3 years to get to that. My interpretation of the third bullet is that whether they knew that they were dealing with an actor or not dealing with an actor, when we looked at their scores, they weren't significantly different. The value of that, which I'll move over and talk a little bit at the end, the value of that is that if when they knew that it was an actor, they either did a lot better or they did tons worse, it would invalidate the rest of the data later on. So again, they're new patients that come to the clinic. They come with their clinic card. They start assessing from the minute they walk in the front door. So the minute they meet the receptionist, those are items that I will show you are on our assessment checklist. They wait in the waiting room like everybody else. They go through their vital signs. They get their full visit. They get their referrals. They schedule their follow-up, and they leave the facility. They take an iPad. They've been trained. They use the iPad, and they mark the learner. They debrief with our USP coordinators so we can make sure there's nothing really odd or anything happen, and then we say goodbye, hope to see you in a few weeks, and we reschedule them. So how are we using USPs for education, for feedback? We have designed clinical assessment checklists that have a set of core generic competency domains that go on all cases: communication, patient-centeredness, satisfaction, patient activation, and then there's case-specific competency domains that go per case. So the depression case is going to be different than the hepatitis case. And physical exam, looking at information gathering, physical exam, counseling and education, treatment plan, and management. And as you can see, our internal consistency is pretty good across all our cases. We have designed them so they're behavioral anchored checklists. So there's very clear behaviors under not done, partly done, or well done. So especially as an SP becomes an expert, they've seen 50 people. And this is the same whether we're talking about unannounced or traditional OSCEs. Our SPs become really expert at being able to assess behaviors. And we keep these as consistent as possible. We were talking about this before I started. We try to keep these common communication checklists consistent whether you're a first-year medical student, whether you're a resident, or whether you're a faculty. So there's a consistency across our institution. And then we report the scores out, the summary of % of all items well done. So we're looking at the best of the best. We don't expect anyone to be perfect. We give, one of the issues is as we're doing this, we haven't wanted to reveal the cases, so we give them summary reports that show their communication skills compared to their cohort on the basic core domains. But what's been really, really important is the feedback, the SP actual comments about the learners. It is really uncommon for trainees or for us as practicing physicians to really have real feedback from our patients. Our patients love to love us or love to hate us. There's a power struggle. They can't really say, you sounded condescending me today, or you really spent too much time at the computer. This is real data. And if they've seen a lot of learners over time, they can get really specific. So for example, I felt I received a lot of options, but not confidence or assurance about how to get better. You can imagine a learner doing that. That's important feedback. Or the doctor doesn't listen well. He cut me off a lot. So we're finding that this is really the really important part of the feedback. So we've sent 67 visits. This was a little pilot project to our medical students to think about how can this be used as an educational tool. Again, this is formative. It's an educational tool. This is not high-stakes assessment in any way. So we sent 67 visits, and what we did is we gave back to them the next day the actual checklist, a little cleanse so they didn't know what exactly was going on. It was a well visit case. They had a penicillin allergy. They were a smoker. Bread and butter medicine about prevention, nothing complicated. And so we really gave this back in real time really quickly to them for them to see how they did, and they thought this was really helpful. So going back to the question that was asked, how are patient activity skills related to other core skills and to training level? That was one of the first things we wanted to ask as we started to accumulate all this data. And so we looked at the case, the fatigue case, which I described before. We had 114 visits, and we showed that the patient activating skills were significantly associated with the overall communication skills, that about 10% was explained. The case-specific patient education and counseling skills explained 44% of the variance, and when we added into the model patient satisfaction, we didn't explain any more additional variants, meaning that patient activation is something that's probably standing on its own and really adding something. We looked at our group of, and it's a small pilot group of our PGY1s, 2s, and 3s, and wanted to see how they performed in terms of developmentally on these core skills: communication, assessment, physical exam, education and counseling, treatment plan, and patient activation. And we saw that the PGY3s did significantly better in communication and seemed to be better at activating their patients. So it's something that you learn and that is getting better at. We have more data.
Why is the second year worse than the intern?
Yeah, and why does assessment get worse every year?
So it's a really interesting question, and there's been other studies out there have shown that second year of training is really difficult, that developmentally people are struggling with amassing a lot of the data, of being able to, there's a reason that residency program isn't 1 year. And that it has to do with developmental, and this is other people have seen this too.
I'm sorry, I came in late. I may have missed it. What is your control? People like us?
So right now it's not a control. We're doing a descriptive study, just like doing an OSCE, using standardized patients to assess behaviors. We're sending our standardized patients into the clinical environment and basically using the same checklist you would use in a standardized environment in the clinical setting.
The reason I'm asking is, how do you know we are not where they are?
It's a great question.
Putting your expectations like 100% is great.
Right, and we're not, and you may have missed it, we're not looking for 100%, which is, we're doing percent well done, right? So we're just doing descriptive, we haven't cut off.
There should be a control group for you to validate.
I'm not sure that we're the control, I'm not sure that would be a control group. I think that would be a population study to understand how well we perform at certain levels of our career. We have sent it in, we've had consent from some faculty member, and it's been really interesting. As we develop these cases, I asked some of my colleagues, I said, would you allow me to send a case in over the next 2 weeks? I'll tell you after, I promise I won't look at any of your scores, but I want you to know, is the case real? Did it feel real? And it was interesting. They felt it was really valuable, and I would love to think about sending it into teams. So as a depressed patient comes in and sees a PA or sees a medical student or sees a resident or sees a faculty member, should they get the same care?
A lot of the, I'm just going to comment, a lot of the differences between first and second year, depending on the program, or even when during the first year, have to do with the volume of patients we ask our trainees to handle. We certainly ramp up, like right now our interns are making a fairly big, steep increase in volume they have to handle. And a lot of the things you're measuring, communication, et cetera, are impacted heavily by how rushed you feel and other pressures. So it's interesting, second years might feel, because depending on your institution and what they're scheduled to do, other distracting pressures could significantly impact, because this is outpatient clinic.
Yes, this is all outpatient clinic.
Worried about the unit, you know? So.
I'm also wondering whether you look at the correlation between the correctness of their assessments and physical exams. If you look as the training level goes up, I'm just wondering whether there's less steps to the correct diagnosis, and that's the reason why there's a decrease as the PGY1 level goes up.
So really good with our, I'll show some data talking a little bit about accuracy when we get there. And also remember, just to make us feel a little better as educators, right? This is what's happening with the standardized patient and the learner in the room. They do go out and precept. So those people who are maybe not doing as well, there's an opportunity for some correction, which is not being measured by this. Right, so just to remember that it's not as alarming as it may feel in the moment.
Seems pretty alarming.
Because you're measuring done really well done.
Yeah, I mean, and our checklists are really well done. Should be what we should be doing. It's
3 points on your scale. There's not a lot of gradation.
right. I'm going to move us on if that's okay, and I'll make sure we have enough room for questions. So we're also, which is really fascinating, using the unannounced standards for quality improvement to our clinical health partners, to our clinical system. So we designed a clinical microsim assessment form. We worked with our clinical leaders. We looked at what nationally the patient safety items are. We wanted it to align with the things they had to report on, they had to measure and that they cared about, right? And I'm sure anyone who has a clinical leadership position will recognize these items as the 2 patient identifier, blood pressure, weight, PHQ-2, introduced, wore a visible name tag, greeted in a reasonable amount of time, was professional, and so forth. So now we're able to actually start taking that clinical microsystem data and give it back to our clinical partners. And we do that on a quarterly basis, right? So we can look since 2011 all the way to 2015, what happened with establishing identity and ask date of birth? You know, why did we go to 43? You know, and they can start asking those questions. They can start planning interventions and know they're going to get this data back in 3 months and see if there was a change.
Nice to know that my alma mater, nobody watches their hands.
Right, so that's a really, so what we learned about that at the beginning was it wasn't observed because they were using sanitizing outside of the room and no one said anything. But from the patient perspective, you didn't wash your hands, right? From the infectious disease control perspective in the clinical, we're doing okay. But whose perspective do we need to consider? So that was some training later on about if you did that, go inside and say something.
We're not doing so okay anyway.
But and then we're able to look at overall clinical function of the clinic. And what we just started really thinking about is using these data for teams. What if you give this data back to an actual team? 2 doctors, the nurse, the patient care associate, and say, this is the problem that your patients are seeing. How are you going to solve it? We'll give you this data back 3 months from now, and start getting people in feedback and audit. And so we're starting a project to really look at that. We had collected this data for a long time, and all of a sudden we woke up one day and said, oh, why don't we slice it in a different way? Why don't we look at teams? And the clinical partner said, hey, that would be really great. We really need that right now. As we're going to build a patient-centered medical homes, we need this data to go back in that way. That's actually more useful than giving it to me for the whole clinic. So again, we're learning from each other what the needs are. And then lastly, as I said, through both our HRSA primary care training grant and our ARC outpatient safety grant, we were using our USPs to answer some educational research questions. The first one, which I'll give you data about, is what I started with, was how did these skills transfer from the OSCE into the real world? And then looking at outpatient safety in terms of charting, documentation, variation in treatment, and the use of the EHR. So do skills transfer from the OSCE to the USP, from the exam to the actual clinic, and we're going to look at communication skills as a piece of that. If you look at this busy graph, you can see that the x-axis is the communication scores done in the OSCE, and the y-axis is the USP communication scores % done well. And so these dots in the middle, the blue dots and the circles in the middle, is about 50% of our residents scored the same. So if you were in the middle of the zone and doing OSCEs, that's how you performed in the outpatient in terms of your communication. If you were low in the OSCE, you were low in the outpatient, and if you were a high performer. Okay, as someone who spent their life dealing OSCEs, that made me feel good. But then it gets a little complicated. When you look at the green triangles, there's a number of people who do worse in the OSCE and better in the outpatient setting. And you can imagine who those people are. If you've been a faculty member in the OSCE, they're nervous. You only have 10 minutes in the OSCE. In real life, the visit's at about 30 minutes or 20 to 30 minutes. People have time to warm up. Your executive function skills aren't so good. You're better, you get more organized with more time. And you can tell those people. But it was this next group, the red stars, were the people who performed really well in the OSCE and didn't do well at all in the USP. And I forgot to mention, when we're talking about OSCE, we have a 10-station annual OSCE that we do with our residents. So we had a good amount of data, and then compared to 3 to 4 visits in the USP. So we wanted to do the best we could, given the small group of our 35 residents. So we said, okay, what is it about that red star group? Because if we as educators can figure something about that, predict who those people are going to be, that would be better for us. So we wanted to know, do the residents' attitudes and clinical functions influence that transfer, right? What else could make that transfer not transfer? So we looked at resident characteristics. What were their attitudes towards OSCEs? What were their perceived competence in their system-based practice, in their situational awareness, in their deliberate practice? And also, did the functioning of the clinic change their performance, right? That would be a hypothesis, right? If the clinic's not functioning, how can they do well? So how did this relate? So when we look at the residents' attitudes and the clinical functions, they actually do influence the USP performance. About 12% of the performance is influenced by the communication skills. 14% of the variance is from the clinical functioning. And 12% of the variance comes from the residents' awareness of their own self-limitation. Those residents who knew that they were terrible at dealing with the clinic really had problems dealing in the clinic. And so there was something that was predictive, which could be helpful to us. So that's only 33% of the variance. So again, let's unpack that again. What else could be affecting that transfer? So we looked at the SP comments, because I said before, that's a really rich place of data of what's actually happening. And so what we learned was, and we looked at those people, especially for those red stars, those people who weren't performing. Computer use was a big issue. It was, completing the EHR was interfering with their communication. The SP said they were typing all the time. The computer didn't work. Their back was towards me, right? So it's a big issue. Precepting, this made me feel better. They came back and asked better questions after they precepted. So there was definitely some change that was going on. The actual functioning of the clinic were interruptions, unclear processes, people didn't know how to get things done.
That wasn't captured in that other?
Because that was captured, and it was captured, but we had more information this way because we were looking at the SP comments. It's the same person, correct, who said the clinic wasn't functioning. And then there were certain issues that you couldn't detect in OSCE, right? That the learner was sort of demonstrating judgment to the patient and that they were failing to really take a personal interest. That kind of tone and flow was more evident in the comments. So then we looked at our residents safely documenting the visits, and are the residents providing safe care? And so we were able to really do a chart review of the USP notes, right? So we have two views of the standardized visit. We have the view from the SP, right, who came in and did those assessments, but we also have the chart view, right, the view from the learner, because they chart it as if it's a real visit. But the visit's standardized. As I said before, everyone is as depressed. The first depression is the same as the second depression, is the same as the third depression, which is unusual. So we did a systematic review of the USP charts. We had 119 medical residents. We had 6 USP cases and 440 visits. And we made abstraction measures from the chart. We looked at the overall quality of documentation, the accuracy of documentation, and that's what we were talking to, the over or under document, the appropriate documentation, are they putting it in the right place and doing it the right way, and the quality of care according to EBM guidelines and practice. I'm going to just touch on some of the things we found. We have a lot of data that we haven't had a chance to go totally through. So are residents safely documenting visits? When we looked at the 114 asthma visits, 95% documented medicine 1. Everyone gave them Flovent or some kind of long-term inhaled steroid, but only 71% documented albuterol, and only 15% documented giving a spacer. So there's a lot of variation in our asthma care. In addition, for the depression case, of the 88 visits, 82% document a positive depression screen. As I said, they're programmed to always be positive. But of those 82, only 52 ended up putting depression in the problem list. And 48% of the 82 didn't put anything that was like depression in the problem list, which is a little concerning if someone has a positive PHQ-2 and a PHQ-9 of 14. It has to at least be thinking about it. And then our well visit case, who was a smoker, also had a penicillin allergy. And of the people, 69% of the visits documented the penicillin allergy. 31% didn't write it. That was scary. Of the people who did document it, 61% of the 69 put it in the right field. So if someone gave a penicillin-like medicine, there would be an alert that came up and the pharmacy wouldn't do it. But 39% put it like in the HPI, in text. Scary. Interesting, our medical students, only 4% did not document the allergy. And going back to someone was saying time of year and time, medical student has an entire 3 hours to see a patient, right? Like they should be doing everything. But they also, 23% of them didn't put it in the right place, which I found really scary. When we looked at are they providing safe care in terms of the asthma case, what percent was documented in terms of educating? Almost 50% educated the patient about how to use the medicine, right? Not good if we give medicine and we don't tell them how to use it, especially if you're an asthmatic. A quarter of them referred them to someone else for education. That's okay. But 29% didn't document at all, that they either did it themselves since the lack of documentation. When we looked at what the USPs had to say, because that's the chart, 36% provided information about a referral, so close, and 62 directly educated. So again, as we've seen in other literature, we as physicians underdocument what we do. And similar we saw in the depression case, 24% started antidepressants. 41% said, I don't feel comfortable, I'm sending you somewhere else, but it's a problem. But again, 35% had nothing written about depression. They were just dealt with it. They were fatigued and treated the sleep. A little worrisome. Our residents...
The USP was similar? You just flashed.
Yes.
I was just curious.
Oh, sorry. The USP was similar. So 26% did not talk. So yeah, out of 35. So again, we're... Exactly, same under documentation. So our residents accurately documented care so now we're back to the accuracy, which was the question that you brought up. And so when we look at documenting the problem, the main problem, in acute situations, asthma, acute knee pain, almost 100%, and that actually goes down. So what we see in the problem list and what the actual real problem is not necessarily as accurate as we'd hope it to be. And again, we looked at accuracy in terms of the physical exam, about over-documentation and under-documentation. Again, we have the USP, what their report is, and then we have the chart report. And not surprising, in the asthma visit, you can see the orange is mostly, for the most part, accurate, but there's a few things that stand out in over-documentation, like in the abdominal exam. 25-year-old coming in with asthma is getting an abdominal exam, whereas in the extremity exam, you may be able to think about what that means, that someone got up on the exam table, got down, their extremities were fine, they saw their extremities. But again, it's not 100%. And then this, I think, was one of the things that really struck us. It was about that we asked, is there variation in treatment for the same case, which is a unique situation to be able to look at, and this can be really informative both for the clinical health system and also for us as educators. So when we looked at labs and test ordering for the USP, there was huge variation throughout the actual case about what was ordered. For example, in the depression case, only 59% ordered a TSH, trying to rule out hypothyroidism, and there was a huge variation in what other was. Why is someone getting an A1C in the asthma patient who's 24 years old, right? It brings up a lot of questions and what is going on. And also things we move towards value-based care. How are we going to, can we use this as a methodology to see how we are improving as we put in different safeguards? Interesting, the medical students ordered more lab tests than the residents. So who is that? Is that the student? Is that the preceptor? It brings up a lot of questions. And then also there's a lot of variation in terms of when we ask people to return, which I think is a safety issue. Anywhere from 1 year to PRN. And again, this is our depressed gentleman who you met at the beginning of the talk. Medical students, again, for what we were saying, had people come back sooner. You can imagine you're on a 4-week rotation. You want to see that patient again, have a revisit. So again, how is this affecting education? And then we looked at billing codes. I know, I'm no surprise. Again, so that tells me as an educator we need to do a better job at educating our learners of what's appropriate or not appropriate. So what are the next steps? I give you a lot of information, and we struggle with this all the time. So what's next, and how is this going to be useful? So when we think about education, I'd like us to see to bring these summaries and these data to our clinical competency committees, that this is another piece of data. As we look at data and make judgments about competencies, this is just another slice that we should add to get a better 360 degree. And we also like to think about, is this something that can help determine entrustability more so than the OSCE or some other things that we're doing? I think there's really great implications for quality improvement. Working with the clinical leadership at our both has been wonderful, and how can we partner with them even more to say to tell us, we're about to do this. Can you add this to your checklist? Can you get this feedback sooner to us? And then starting to move to providing meaningful feedback to the teams. And as I mentioned before, thinking about identifying need and barriers for value-based care, what's going on with our lab ordering. But I think uniquely, it's in the patient engagement piece. As we all move to patient-centered medical homes, we really have a unique way of having really expert patients who really have a perspective, who can really tell us, is our system working or not, in a way that it's really hard to get from some of our patients. And I think it's a true way of seeing if we're really engaging people or not. Our next research questions is we're really interested in the transfer of information. So there's been a lot of stuff written about social and behavioral factors that are responsible for health disparities, like housing and financial issues. What happens when that information is disclosed? Who on the team gets it? How do we act on it? Should we build systems into that? And so we're thinking a little bit about teams and moving of that information, as well as the use of health information technologies. I talked about how to use the EHR, how can we teach them to be more useful? Why are they putting it in the wrong place? Is that a workflow issue about the allergies? And what about the accuracy of that information? Limitations, there are a lot, and again, this is something that we've been working on for a while. They're all new visits. How can we do a follow-up? Should it be a phone call? Should we send them in? A new visit is one type of visit. It's really a biopsy, one moment in time, and a highly controlled, in-depth assessment. So does it tell you about everything? No, but on the other hand, each visit we do is 1 minute at a time and can make a big impact on our patients. So how do we look at this, and what are the right ways to combine these? The level of feedback, we're not fully disclosing it because we don't want to be detected. And then everyone says cost and expertise. It's really not as expensive or as hard as people think, as long as you have a clinical partner. If you have a simulation center, you have actors, you know how to train them, you have checklists. It's about getting everyone in the room together and saying, hey, this is important and this information is important, and how can we use it? So this has been our journey, which has been really exciting, and really happy to get to share it with you. We think that unannounced standardized patients take advantages of standardizations to test the provider and the team and the system, so you get a 3-for-1. That it really gives us actionable and compelling feedback to our healthcare professionals, that it complements our OSCE. We shouldn't get rid of them, but this is something in addition. That it really incorporates the patient perspective and rigorous behavioral-based assessment. So it's not just patient satisfaction, we're getting a little deeper. And it integrates the patient experience and perspective on the care into our whole system. And it gives us a unique window on outpatient safety. So ultimately, it's an innovative tool in many ways to do it, and I hope this sparked your interest and made you think of ways that you could think about incorporating it. I just want to many thank yous, especially to my colleague, Colleen Gillespie, who's my partner in crime, who does most of the biostats for this, and some of the designing of our assessment forms. Andrew Wallach, who leads the Bellevue Ambulatory Clinic, Barry Bateman at Gouverneur, all the residents, all our standardized patients, my faculty collaborators, our SP coordinators, and our statistician. And as I mentioned before, this work was funded by 3 different grants. So thank you. And